We have people here at our Biomarker network meeting from Europe, and we are eating breakfast here in California. So technology at its best, maybe. We're happy to welcome everybody. It's about 20 years. Tressa Seaman and I have been doing this network. Liz Nielsen has been the project officer since the beginning. Time passes faster than you realize. When we began this, we were all quite novice at measuring biomarkers. We call it the day of cholesterol and hypertension. We are now into a much different world. Our aim was to make to get a scientific world where people were able to measure these things in populations in a reliable and valid way. And much of that has been accomplished. It's not over by far. There are many new biomarkers, but we used to have the sessions on how to and how not to measure biomarkers. Now we're at the point where we have incredible results from studies all over the world. And that's what this meeting consists of today, Friday, and Monday. Mainly sessions on results. I guess Monday is still a little bit on measurement because that's on telomeres. But today we have results. People have 4 papers presenting different studies, different topics, all under the rubric of biomarkers and stress. This network is part of the activity of our center, which is devoted to the same topic primarily, and Steve Cole is joining us as one of the primary investigators in that center. So he's joining, and he has joined us since the beginning when he first did a 6 or 8 hour session on genes for dummies in Dallas, as I remember, at this biomarker network. Or sorry, genes for demographers.
I don't recall any editorializing on dummies.
So. So we welcome him, and he and Tressa are going to do the question introductions or tapping on the shoulders of people who've put up their hands. So everybody who's on the panel, you can who can speak now, you can see on the screen, and we have to unmute anybody who's going to ask a question. Now, we only have about 80 people signed up for this webinar, so we think it's possible to actually unmute you and allow you to ask your question and get the response, and then we'll look for the next person to, and we'll announce and unmute. If things get too complicated, we could end up putting questions in the chat room, but we think we can have the interaction where people ask their own question. So that's what we'll try to do. We'll have 15 minutes for each paper to present, and then we'll have at least 5 minutes after that so we can react to the material in that paper, and then we'll have some time at the end for general discussion. So the first thing on the agenda for today, though, is to have a few words from Liz Nielsen. So Liz, as I said, has been the project officer with us since the beginning. She has really spearheaded the work within the NIA Behavioral and Social Research Group to actually try to measure mechanisms through which social, behavioral, psychological, policy factors get under the skin. And so we have been very grateful to her over the years. Now she's taken on the role of the division director of BSR. We may not see her as much as at our activities, but I think we'll see her at lots of different activities. So Liz, do you want to give us a few words about where you see things now, and what's your view from Washington?
Sure. Well, my view from Washington is probably a lot like your view from wherever you're sitting. It's a computer screen and my front yard or a view from my balcony. I think though that does sort of prompt me to say just that, here at NIH, we are sort of steeped in COVID-19 research and not limited to, research on vaccines and treatments, but also in the social and behavioral sciences sphere, really looking at sort of the uneven impacts of this pandemic on society and the social, behavioral, economic, and psychological factors that might account for that, and what we might do to ameliorate those impacts and prepare ourselves for the next pandemic should one come. So there's been a huge investment of my colleagues in BSR and across the NIH behavioral and social sciences field in trying to do this. You may, if you follow the NIH guide religiously, you will have seen a few announcements come out in the past couple of days called the RADx-UP initiative related to COVID-19 testing in vulnerable and health disparities populations. So that's just one example of some of the work going on from here. So I think the view from Washington, at least from the NIH perspective, is pretty heavily focused on those things, but also on sort of keeping the momentum going on the strong research activities that we support. So for those of you who don't know BSR, that's the Division of Behavioral and Social Research. We support behavioral, social, psychological, and economic research on aging at both the individual and the population levels. And a lot of what we do tries to bridge those levels of analysis. And just to this network, so we have been supporting these high priority behavioral and social research networks for a number of years, as Eileen mentioned, with the real goal of stimulating some transdisciplinary work in emerging areas of science that have been identified either by our National Advisory Council or by National Academy workshops or other convenings of experts that we have supported to try to help push boundaries in our fields and also to attract new investigators into aging research. And what's unique about the networks is that they really often require expertise that's beyond the capacity at any individual institution. And also that they sort of are the answer. It's an R24 grant mechanism. They're sort of the answer to that sort of flexible thing scientists need to do the work needed to sort of build new conceptual frameworks, experiment with and develop new methodological advances, support the development of infrastructure, and also to be able to turn on a dime to kind of address problems that are arising in a field to serve a field at large. And so the way that the Biomarker Network has done that, as have others, is to sort of hold meetings, conferences, support small scale pilots, do training opportunities and other activities. And what's nice about the Biomarker Network, which is one of our longest running networks, is that it brings together the population science experts with the biological and psychological laboratory science experts to really think about this big question about how does the social environment get under the skin and become biologically embedded, and how can we best explore that with the best methods in our population-based studies on aging. And so the network's been working hard to improve our measures of biological risk for late life health outcomes, and also to do what can be done to ensure the comparability of the measures that we have across a number of our large-scale studies. So it's been a real thrill to see the growth of this activity over the past years, and I think this being able to turn on a dime and host a bunch of webinars is sort of typical of what our networks can do. The science goes on even when some things ground to a halt. So I appreciate the opportunity to say a few words, and I'm really looking forward to the discussions. I'll be with you for most of today, and then for the third session, I'm unfortunately unable to join the second one, but I think it's great that so many people remain engaged under these circumstances. Thanks a lot.
Thank you, Liz. I think we'll turn right to the papers now. And the first paper is going to be presented by Kim Kornack, who I see has now unmuted herself and ready to share your screen.
Yes,
hopefully this works.
I am.
Good. We were introduced to Vietnam last year, and we look forward to hearing the results now.
Okay.
Great.
Can you see just my slide and not my comments? I want to make
Looks good. Kim.
And you can hear okay.
Yes.
Great. So it is a great pleasure. I want to echo the comments and thanks of Liz. Eileen and Teresa have been very welcoming. We are in the newbie category and sort of entering with baby steps into the world of biomarker research. And the network has been incredibly helpful and supportive to our team. So I want to first acknowledge my co-authors and support from NIA. And in this paper, we're going to be asking what we can learn from a middle-income post-conflict population about how aspects of biology and social context and their intersection signal perceptions of subjective age. A bit of background on the concept of subjective age really began as a more psychosocial construct in the 1950s, but especially with advances in data such as the HRS, there's increasingly a use of a biomedical model to understand better this discrepancy between how people feel in terms of their age and their chronological age. So more recent research over the last few years gives us some sense that older subjective age, which is a signal of bad things to come in terms of morbidity and mortality, correlates with many biomarkers, albumin, cystatin C, as well as anthropometric measures of frailty and health. I should point out, though, that much of the research that has come out of HRS is very valuable, but it sort of repeats a trend in that most of this research is done in the US or Western Europe. There's been very little research on subjective age in non-Western or low and middle income countries. And these are important to look at when we're thinking about a construct like subjective age because it is so implicates context, culture, social structure, and so on. So there have been a few studies recently conducted in China, in the last year or so, a couple in South Korea and Japan as well. And then a small subset of studies conducted amongst veterans in Israel that really kind of look at PTSD, exposures to extreme forms of stress in war and how those relate to subjective age. So these studies are getting us to kind of question this kind of sense that, well, most people feel that their subjective age is younger than their chronological age. We see quite different things across different settings. So in our paper, we're kind of echoing recent research such as by Yannick Stefan and others, where they're trying to pull together these traditional psychosocial measures, looking at context and life course and how those come together and merge with biomedical perspectives to shape subjective age. So there's been some work on, for example, the experience of ageism and how that is reflected in biomarkers and then subjective age. And what we'll do in this study is look at this slew of really difficult and stressful life course experiences in Vietnamese war survivors, those who survived famine, for example, in World War II, war stressors, land reform, and then also many who experienced different forms of military service and how their subjective age is reflecting those experiences in part through biomarker indicators of their health. So I wanted to share a bit, getting to sort of give you a sense more of the context. This is our dependent variable, and it shows that our sample really skews towards an older sense of subjective age. One thing that's the importance of context comes out when we look at the contrast with HRS. Oops. And you can see that our sample, which is only about a year and a half older on average than the HRS sample in 2016, really suggests that they're feeling a lot older. And so we want to know, is this because of the war and the stress? Is this because life expectancy is a bit shorter in Vietnam? Something to do with the sort of epidemiological and sort of disease context, or what's driving this sense of older subjective age? And so we have a few hypotheses that subjective age will be increased with those who've had greater exposure to wartime stress, that individuals who have biomarkers that suggest poor functional and physical health will perceive their age as older than chronological age. And then also that indicators of nutritional deficiency that we capture both in our survey markers, or survey indicators, and certain biomarkers will correlate with older subjective age. And that has been a somewhat robust finding in some of the HRS research, that these nutrition biomarkers do pan out for subjective age. So a bit about our data. The Vietnam Health and Aging Study, we collected the first wave of this in 2018 amongst 2,447 people who were 60 and older. This is the American War cohort, so they were in their young adulthood between 1965 and 75 when the peak of that war was taking place, and they served in many different roles. The study is really designed to capture their diverse exposures to wartime stress and war participation. And that's partly through how we did the sampling, where we did a purposeful selection of 4 districts that were differently exposed to bombing. Those are indicated in the map. And then we also collected a wide range of survey indicators on war stress exposure. The biomarker data that we collected in 2018, amongst as much of the full sample as we could as possible, I think we have about 95% of the sample has at least one biomarker indicator. It was collected by the Hanoi Medical University staff that was on our team, supervised by Ellie Brindle at CSDE at University of Washington, and we conducted it in 12 commune health centers. We collected anthropometric data, a hair sample for doing cortisol analysis, and then a finger prick capillary blood sample, which we used for, not for dry blood spots, but we've stored samples for doing ELISA and multiplex assays with that sample, and then did some point of care tests of CBC and A1C. I can elaborate later on why we're focusing now just on the CBC data from point of care, but we're still in a process of working through the stored sample assays. So some of the covariates in our model. To the left, I show the biomarkers and the self-reported health indicators in this specific study, where we're focusing more on the anthropometric data and then the measure of hematocrit from the CBC point of care test. These are kind of, in some ways, biomarkers that might also be perceived in terms of how people feel in terms of their energy, their strength, their lung capacity. And then to point out on the right, the exposures to war measure, first of all, severe childhood hunger, that's not really war, it was related to World War II. A lot of the hunger experience, the famine that Vietnam experienced in the 1940s was severe, but there was also land reform before the American War, and then a lot of shortage during that time. We assess involvement in the military that was involved different levels of stress that we capture in a more clear way with 2 indices that capture exposure to combat and different sort of forms of violence during the war. Those were not only including veterans, but also civilians had many of those experiences. And then a malevolent environment index about whether people experienced evacuation, bombing of their village, fear of dying, and different shortages during wartime. And then we also include in the models current measures of psychological distress. So I wanted to spend a little bit of time, it's not related to the specific questions of this study, but showing how our biomarker measures associate with our wartime stress exposures. And I just show a few bivariate associations. By age, these aren't controlling for age, and age does play a small role in these, a little bit of difference in terms of the more war stressed being older. So I'll show those here. So these are showing the associations in the bivariate between the experience of childhood hunger and currently measured ADLs, peak flow, grip strength, calf circumference, and BMI. And there's generally a pattern. These are the ones that are the statistically significant biomarkers, and you can see that sort of aging effect of those exposures as measured through these indicators. The other indicator that we look at is the wartime malevolent environment exposures. On that index, we've grouped people in terciles, and again, we see that those with the more severe numerous exposures to this kind of stress have more ADLs, chronic conditions, lower peak flow, lower grip strength, and the calf circumference is there's an interesting relationship there between men and women that differs, and we'll talk more about men and women and what they experienced in war and military as we move into the multivariate analysis. So what we'll show next, are our multinomial logistic regression analyses. We adjust for commune level clustering, and we're first going to look at the relative risk ratios for feeling older compared to one's chronological age, and then feeling younger than one's chronological age. And we introduce the covariates in groups so that we can sort of see how bringing in the biomarker measures sort of attenuates or influences those life stress exposure measures. All of these models control for this list of variables, and our analytical sample is about 2,100 people. So first, looking at the relative risk ratios for feeling older than one's chronological age. What we see in the analysis here is that there are some associations. This is just showing the life course stressors first. And we find in these results that those with severe hunger in their childhood and with more malevolent environment stressors are at a greater risk of feeling older than their chronological age. Those with formal military service show a lesser risk of feeling older than their subjective age. And this is after we've accounted for those military service individuals having experienced more stressors that are related to combat and violence. So in some ways it's pulling out the impact of that social status of having served in the military. If we move across the models, what we see is that the effects of hunger and malevolent environment stressors are attenuated in that second model when we bring in the health biomarkers and also the current psychosocial or psychological distress indicators. This is the biomarker part of that model. And again, I'm just sort of showing these step by step so you can see the results. But we see that individuals who have more ADLs, more chronic conditions, smaller calf circumference, so on the below a sort of threshold with less muscle mass, and those who are underweight have a greater risk of feeling older. And then there's a small association that becomes non-significant related to abdominal adiposity, the waist height ratio. Those who feel younger than their chronological age, there's a much lesser likelihood for those who experience severe childhood hunger, but those who experienced combat and violence stress exposures during their early life course actually indicate a slightly greater risk of feeling younger than their chronological age. But what's important is that difference between the first model and the second model. So this becomes statistically significant after we account for their health status and biomarker indicators. It suggests that there's an effect that is more psychosocial in nature, linked to that sort of being essentially in a lot of a combat role during the war. Feeling younger than one's chronological age is less likely for those with weak grip strength, for those who are underweight, and it is more likely for those with a higher percentage hematocrit. Okay, so a bit of discussion of our results. What we see is that undernutrition over the life course, measured in several ways, increases the risk of feeling older. That malevolent war environment stressors seem to age survivors in terms of this measure of subjective age. A kind of unexpected result, but one that we think we can get our heads around, is that military veterans and the combat stressed report more youthful subjective age, which might have to do with something that is linked to a survivor resilience or some benefits of military service. And there are several biomarkers of aging and frailty that correlate with older subjective age. And our life course stressors are partially expressed through those biomarkers. So just to conclude, a few limitations of the study to point out are the issue of selective survival amongst those who we are able to interview and collect biomarker data amongst in a cohort that experienced a lot of hardship, stress, and violence and death early in life. We are not quite, but we are close to the point where we can assess inflammation and other processes that we're very interested in once we have our stored blood samples assayed, maybe next year. When this meeting happens again, we'll hope to do that. And then subjective age is a complicated construct, and we have a single categorical measure of that. So we're really looking ahead to making this a longitudinal study, hopefully if the conditions align and we can collect our wave 2 data under the circumstances that we're in. We plan to do that in 2021. That should help us to look at issues like bidirectionality and longitudinal associations between these war stressors, subjective age, and then sort of emerging mortality and morbidity in the sample. So I'll wrap up there, and our references and any questions that folks might have, I'd be happy to take.
Thank you.
So the floor is open if people want to raise their hands if they have questions.
There is one question, Tressa, in the Q&A from Roseanne Kenny.
So Steve is managing the chat.
Okay. You want to unmute
so
Roseanne Kenny?
There you go. Well.
What Roseanne?
I don't seem to have.
Yeah, I've got it. Roseanne's asking, do you have any data on physical activity to perhaps explain the association with military service?
It's a good question. We have, in wave 1, we did not collect extensive physical activity measures. We are planning to use some of the techniques from IFLS or LASI for wave 2. In part because of the nature of the sample, we need to be thinking pretty creatively about how physical activity is expressed more in their day-to-day activities and ongoing work like agricultural work. And I know that some of the other studies do that, but physical activity is a health behavior dimension that we did not include in this analysis. We do need to look, probably incorporate we have measures of smoking and alcohol use that would probably also inform this and that other subjective age studies do. But thanks for the question. It's something that we need to definitely enhance as we move this part of the research forward.
Great. We have another question from Jason Boardman, who's asking, how important is the timing of the US-Vietnam War for this cohort, especially with respect to selection? Is this why the effects are weaker among men, for example?
Okay, so the last part is making me wonder about that. So, I mean, I think in some ways, we struggle with the selection question a lot. I think anytime a study begins in older adulthood, we'll have the sort of like selection of mortality that's taking place over time. And this population had many stages where selection would have had a role in sort of affecting who has survived to this point. The wartime and the wartime more strongly impacted deaths amongst men, but not exclusively men. So I do think that some of the positive results that we see for the combat exposed are more common amongst men, and that might be that resilience effect is because that survival has been relatively not rare, but there was a doubling of mortality amongst men in this time period. So we're at the early stages of being able to understand that. We collected SIBSHIP rosters, full SIBSHIP rosters, and we're going to look at those to look at the timing and some rough sense of cause of death amongst the siblings of survivors to get a better sense of who it is that we're observing in our study in terms of gender, when they were born, and some rough sense of their sort of family background.
Kim, I have a follow-up question related to that. So, you know, your results on the sort of the surprising benefits of combat exposure in older adulthood are not, it turns out, as, you know, rare as we might, you know, generally expect. There were similar observations in the kind of greatest generation analyses of World War II. Brandon Court has made similar observations in people who were child soldiers in the Nepal People's War. It's not to say war obviously is, you know, sort of all fun and games, but there is an interesting capacity to extract meaning and significance from traumatic experience that often, you know, sort of befalls these survivors. They often feel like they've contributed to, you know, sort of the progression of society towards a more just and equitable, you know, modern state. Do you have any capacity to answer, you know, questions about whether that kind of meaning making might be going on in your study?
We do. So we did ask, there's a series of questions. We took a lot of our war exposure and then some other questions that we asked to veterans from some of the, like the Vietnam Veterans Readjustment Studies. And those are asking a lot about trauma exposure, but they also ask questions about like camaraderie and the extent to which people felt like they were part of an important cause and that it's had meaning for them. And I do think that would be a useful thing to look at in this study as well. But I think it's the contrast between the greatest generation and their sort of interpretation and reflection on that cohort service versus the Vietnam War generation in the US would be an interesting parallel. And I think the Vietnamese who are on the side of the North and what, you know, the experience of victory and struggle is probably being interpreted in a way that's closer to that World War II generation than the US veterans who fought in Vietnam. So yeah, I agree. I mean, I think looking at those, but then I think also thinking about, does it pan out in terms of like a survival effect will be interesting to see. And is it expressed through this biological or psychosocial pathway? So,
I think
for that.
Thank you. I think we should move on to the next paper. And Duncan Thomas is going to present here on cortisol concentrations, and he's going to have a natural disaster in Indonesia. Duncan, looks like you're sharing. Fine.
I'm trying.
It looks good. Ooh.
That doesn't look so good to me.
Oh, it was better. Now it's fine.
How is that?
Good.
Good. All right, let's go. So first of all, thank you very much for letting us present this paper here. The paper, as you can see, is collaborative with Ralph Lawton, Elizabeth Frankenberg, Teresa Siem, and Eileen Crimmins, all of whom are here, and Cecep Sumantri, who is one of our Indonesian colleagues, and he's not on the call. One thing to say is that this is a paper that would never have been written without the Biomarker network influence, and it truly is an outcome of that product. And we have benefited enormously in the work we've done from being a part of the network. And so thank you very much. And also grateful to NIA and ICHD and the Wellcome Trust. So this paper is very good follow-on to Kim's paper. And it is asking the question of what is the long-term effect of exposure to major natural disaster on cortisol concentrations. And what we're going to do is leverage exposure to a large-scale natural disaster to measure the effect of stress on the HP axis, which we will measure using cortisol in the hair of adults. And we'll do this over the long term, as in 14 years after the disaster. We're using hair cortisol. We took hair from close to the scalp, about 3 centimeters. We're using an ELISA kit to measure cortisol in the hair and therefore avoid all the diurnal variation in cortisol. And so we think we have a marker of cortisol that is around about for the previous 3 months. And the literature on major stresses and downstream cortisol concentrations is surprisingly mixed. On the one hand, there's evidence that large-scale stresses have people present with higher cortisol and elevated chronic stress. But there's also literature on people presenting with lower levels of cortisol as measured over the long term, 3 months, something like that from hair. And this hypercortisolism has been interpreted as an indicator of burnout of the HPA axis. And there's a number of papers dating back to Bruce McEwen's early work at least in 2009 and earlier as well, and some more recent work. And so there really isn't a clear picture of what are the impacts of large-scale stresses. And importantly, little is known about the long-term impacts of these large-scale stresses. And very little evidence, I think, can be interpreted as causal. And that, I think, is in part what we're trying to contribute. So the disaster. The disaster we're going to talk about is the 2004 Indian Ocean tsunami. It was spawned by an earthquake. It was registered 9.3 on the Richter scale off the island of Sumatra in Indonesia. Sumatra is at the northern end of of Indonesia, and you can see on the map reaches up towards next to Malaysia. The earthquake occurred at 8 o'clock in the morning on Sunday, the 26th December, Boxing Day in the England and colonies. It was huge. It shifted the North Pole by 2 centimeters.
Duncan, your slides don't seem to be advancing for us. I'm sorry, when you said the map, I realized you thought we saw it.
So.
There we go.
Do you see the slides now?
Yep.
Yes.
Maybe the best thing is to do that and just use these because maybe they won't. So let's see if this works. Let me know if they don't. Thanks, Eileen. So there you can see the map. The tsunami, the waves from the tsunami were felt right across the Indian Ocean, but Aceh, the province in the northernmost part of the island of Sumatra, was the hardest hit. The epicenter of the earthquake was about 160 kilometers away from Aceh, and in Aceh, 170,000 people died. That's about 5% of the population. Over 750,000 people were displaced, and in addition, entire livelihoods were destroyed. So this was a stressor that was very multidimensional and had huge impacts on the people who were directly affected. In addition, this is an area that was not thought to be prone to tsunamis. First, there hasn't been a tsunami on mainland Sumatra for at least 600 years based on archaeological evidence. But in addition, the experts, the scientists did not think that there would be a tsunami in this part of the world. So they didn't even have buoys in the water in the Indian Ocean, whereas there are buoys all over the Pacific Ocean. Obviously that's changed. And so the key point for us is this was a very large and unanticipated shock. And so therefore we can leverage that to try to understand what the impact of that was. Of course, the shock was across the, everyone along the coast of Aceh was at risk of being affected by this. And in some places, the communities were just completely devastated. There you can see a beach in town that's just been wiped out by the tsunami, and that was taken a few months after the tsunami. And down on the lower part of the picture, you can see not a village in our study, but a village on the Acehnese coast. And on the left-hand side is a satellite image a couple of days before the tsunami, and you can see the aquaculture, there's agriculture, and there's a village and some roads. And on the right-hand side, 3 days after the tsunami, all of that has just been turned to bare earth and it's just been completely scarred. And that is that's the total disaster part of the tsunami. But what is important, incredibly important for us, is which communities were affected. Everyone was at risk because depended where the epicenter was, but which communities actually got affected depends on idiosyncratic features of both the land on the coast and the seabed topology, as well as the wave direction. Importantly, for example, just north of Kruang Kala here, there is a promontory, and the area just north of Kruang Kala was completely protected, and they did not bear any direct impact of the tsunami. And that's the kind of variation that we're going to exploit. The fact that both where damage occurred was outside of the control of respondents, and the fact that it was completely unanticipated. We show in other work that was impacted, which communities were impacted along that coast, is not related to pre-tsunami characteristics. And so we think that, at least to the extent that whether you were in a community that was exposed to the tsunami and had heavy damage versus maybe less damage or not directly affected, that we think is plausibly exogenous. We think there's evidence in other papers we've written and relevant for this paper. And so we think we can identify the causal effect of major stresses over the longer term. So the data. We're using STAR, a study of tsunami aftermath and recovery. One of the unique features of STAR is we have a pre-tsunami baseline, not because we predicted the tsunami, but because the Indonesian government runs an annual survey and they collaborate, they were willing to collaborate. They asked us to collaborate with them to actually follow up people who were interviewed 10 months before the 2004 tsunami. That survey is very, very large. It is population representative at the district level. And so we included all districts that had a coast along Aceh and along the west coast of North Sumatra. And it's a population representative household survey of about 40,000 respondents. We followed up the survivors from that survey. We followed them annually for 5 years and did a 6th survey at 10 years. We've been incredibly hardworking at following people up, and we followed up 97% of the survivors at least in one survey, and typically most of our surveys we will re-interview 95% of the target respondents. At 13 years, we did a subsample of respondents in which we did an extended biomarker and cognition assessment, and that was on about 7,000 respondents. And then a year after that, we collected hair samples from a subsample of those respondents. And we had a target of 661 respondents. We set them to be age 21 at the time of the tsunami, at least 21 at the time of the tsunami, and so they were at least 35 at the time of collection. And of those, we have valid cortisol measures for around for 93%. You can see why they may not be have been measured. And there you can see two of our enumerators, one cutting the hair of the other, and behind them is none other than Ralph and Cecep Sumantri, our collaborator. The results from the study. So the model we're going to present, incredibly simple. Cortisol has a long right-hand tail, is asymmetrically distributed. So we'll use log cortisol to get something that looks very close to normal. And we're going to measure that 14 years post-tsunami. And our first, most simple model will compare log cortisol of those living at the time of the tsunami, because we have the baseline, we know where they were, in a community that was heavily damaged. So we know what their experience was. A community that was somewhat damaged relative to community that was not directly affected. So we'll have three indicators, and the not directly affected will be the excluded group. And that measure of damage is based on the satellite imagery that I gave you earlier that we validated with interview assessments and so on. And then we'll do these separately by gender, because that's important, and we'll control age and education, whether the respondent smokes, dyes their hair, and so on. We won't report those for the sake of time. And that's our first model, and here is our first set of results. So we have females on the left-hand side, males on the right-hand side. Among females who were living in areas that were heavily damaged at the time of this, when they were living there at the time of the tsunami, we see that their cortisol level is 30, this is logs, so you can interpret this as percentages, and we multiplied everything by 100. So that is a 29% lower cortisol than the reference group, which is the people who are living in areas that were not directly damaged. And then there's an immediate effect for some damage. Red indicates that it's significant at 5%, and the difference between heavy and some damage is significant at 10%. There's no evidence of an effect here for males. So we turn next to a follow-up model in which we add to that model individual specific measures of post-traumatic stress reactivity. We use PTSR, which we assessed 3 times, because we can then get an indicator of not only how bad things were at the time of the tsunami, but how persistent these effects were on those people. We also have models where we use their actual exposures, that, you know, they saw people die, they had family members die, they saw people struggle, they got caught up in the water. This, we think, is a good one marker as a good index that summarizes the experience. And as I say, importantly, we administered this both soon after the tsunami in our first survey, again in the next year, the survey a year later, and again in a survey 2 years later. So we actually can document how that changed. Now, of course, PTSR declined for everyone, but it declined at different rates for different people, and that's what we'll exploit. So panel B here just repeats the same model with these additional covariates. So you can see that the overall effect of being in a heavy damage community at the time of tsunami that effect has not changed, but the impact of that exposure is greatest for those people, those women, who not only had high PTSR, but had high PTSR that persisted through to at least 2 years later. And so it's those are the people who seem to have the most impacted in terms of this hypercortisolism impact. Our third model exploits the fact that we actually know where you were, what community you were living in, so we can actually sweep out any of the location-specific characteristics at the time of tsunami, if you were living in a wealthier or not so wealthy community or something like that, and maybe that affects your, how stressful the whole experience was. So we can sweep those effects out by including community fixed effects, which of course sweeps out the covariates in model A, but we can still include PTSR and take into account all this this location-specific unobserved heterogeneity that's fixed, that affects cortisol concentrations, and really focus on the individual exposures. And that's in model C here. And the remarkable result is that adding the community fixed effects basically has an imperceptible impact on the coefficient estimates and absolutely no impact on our interpretation. That is that the females who had persistent elevated rates of PTSR, post-traumatic stress reactivity, present with significantly 3%, 2.7% lower levels of cortisol. So to sum up, first, we leveraged unique data in STAR that measures exposure to natural disaster at the time of the disaster for a population representative survey across all age groups. These people were exposed to a very large scale set of major stressors, loss of family, loss of livelihoods, and we followed up those survivors for this study for 14 years. We find statistically significant negative impact on hair cortisol levels among females, whether we measure that exposure as exogenous exposure based on where they lived at the tsunami, and or whether it was persistently high levels of PTSR. So what we find is clear evidence of hypercortisolism, i.e. burnout of the HPA axis, sort of things that are seen in, for example, pediatric ICU nurses who have dealt with children with cancer. I think that was one of the ones McEwen discussed, one of the cases McEwen discussed. And so we're seeing that really presenting a long time later and in a group of people who really had no control over what exposure they had. And that suggests that these negative health impacts of adverse events likely persist far into the future and seems to us to be a really important thing to be concerned about. We do find among females, among males, excuse me, the same direction of effects. They're not as large and they're not significant. And that's possibly a function of a sample size that maybe if we had a bigger sample, we would have picked up the significant effects, but that's, the impacts are certainly in the same direction for the males who had persistent elevated PTSR. And that's it.
Floor is open for questions. If you want to put them in the chat or raise your hands. Michael is monitoring the raising of hands.
You guys can also put them in the Q&A box as well. We're monitoring all of those. So.
Hello, can you hear me?
Yep.
This is Lynn Schmitz. I'm wondering if you experimented with other ways of measuring the shock so that you can see if it's kind of dependent on the measure that you're using for the shock. For example, I don't know, like wave height near the shore where these people lived. And measures like that may also allow you to have a model where you keep in the fixed effects, the community fixed effects in addition to the shock.
So we have measured the exposure to the shock in numerous ways. Our best individual measures are measures which we asked our respondents, and they told us that they had, we found out from our rosters and extended rosters, that they had family members who died, or that they themselves were swept up in the water, or that they saw other people being swept up in the water themselves and saw other people die. So that's one set of measures, and we have used those. They, you can either create an index of those, or we can use them independently. And obviously you start getting into all sorts of complicated multiple testing ideas. And so that's why we thought presenting results on PTSR as our main sets of results is a good approach. If we use those markers, the same patterns emerge, although the when you're stacking on a number of different covariates, whereas PTSR creates a nice index. We did measure wave height. We don't measure wave height at the house because, of course, a lot of the houses disappeared. So we don't know exactly where your house was. When we found a lot of the people we found, you know, as I said, 750,000 people were displaced. A lot of the people that we followed up had been displaced by the time we found them post-tsunami. So obviously they had to have survived, but many of them had moved to camps or moved away. By this time, I believe over 60% of our respondents have actually moved from the origin sites. So these studies that just follow people in the origin sites, so it kind of got to select a sample. And so we can't measure specific heights of where people were living, but we did get wave heights. We measured them from on a modeling basis, and we also measured them by doing it on things like those housing structures or buildings that still existed. We measured the heights on those, and quite frankly, if the height was 6 meters or 3 meters for this place, it was probably about that right across the board, because these communities are really enumeration areas and they're relatively small areas. So there's not a lot of slope in our study areas per se. And that's a sense in which we would still be having to use community fixed effects if we were to use those.
Okay, thank you. Very interesting study.
Thank you for the very
Duncan,
interesting.
we also have a question from Roseanne.
Are you on mute?
So
Duncan,
there's a
question.
Hang on. There's a question from Roseanne Kenny about what % of inadequate hair length did you encounter relative males to females?
So all the bald people were male, and we didn't really have any inadequate hair length for, apart from the bald people, for males or females. I think if we couldn't get 3 centimeters, you mean if inadequate means could you get nothing at all? The answer is no. We could get some hair. If we only got 1 centimeter of hair because the person's hair was relatively short, then we would just use that, and that would have been much more, to the extent that happened, it wasn't very frequent. I think there were like 10 cases like that. That was very much a case for males. Very few females have short hair. And we were surprised. We had very low rates of refusal relative to what we expected, which I think is partly because we have built a very strong relationship with our respondents.
Duncan, Kim Koronek has her hand up. If we could get her unmuted.
Okay, Duncan, thank you so much. It was a very interesting presentation. I've been thinking a lot about this sort of like acute severe stressor of the wave hitting at the actual time of the tsunami as compared to ongoing and chronic stressors that would be maybe in particular communities in terms of economic recovery and the difficulty of life in the post-tsunami setting. So I'm wondering if you have a sense across those communities in terms of like what recovery looked like, how long it took, and if it was uneven, or if your survey can capture any of that kind of stress that would have been after the tsunami event.
Great question, Kim. So yes, it's a key, it's absolutely critical. It's really a fantastic issue. So one of the reasons that we've been putting a lot of work into satellite imagery is because what we're trying to do at the moment is use machine learning to actually measure changes in economic activity, the reconstruction of post-tsunami, to actually capture these effects. Because these people have moved all over the province. In fact, some of them moved to outside of island of Sumatra altogether, and we followed them to Java. And so obviously these people who've moved all over Aceh province, they may have been in a place that was very damaged before, but now they've gone somewhere else. And we would like to capture that as well as the regrowth and development in the places where people have stayed. And so all of these things we are trying to measure. There was no reconstruction for at least 18 months post-tsunami. The initial thing was just to get people to get to camps, have them have some basic services, get them having, kids in schools, health services, and so on. And in about 18 months, 2 years, we can start seeing some of the reconstruction effects. And we are working at the moment on building models of the impact of reconstruction, because as you say, there was a very different exposures for different people. Some people were able to actually make out very well because of the tsunami, because prices of things like rice went through the roof. If you owned a house and it was in Banda Aceh, for example, and people moved there and they started renting, you could start making a fair amount of money. So it's not that everyone had a hugely negative effect. I don't think we're going to be able to pull any stuff out from the cortisol analyses because it's a really small sample, but we've been doing C-reactive protein and A1C markers, as well as blood pressure and adiposity, and we're trying to measure we are seeing that those biomarkers, and they've been measured much more frequently, those biomarkers are changing over time, getting really bad and then improving. And we're trying to relate that to these people's economic lives, and both at the community level and at the individual level. So great question. It's complicated, and it's, again, the CRP and A1C stuff we're doing just totally a result of this incredible biomarker network experience.
Thank you. I'll just add that I think that I have a former student who's looked at the effects of Hurricane Mitch on childhood health, and has looked at, in part, some of that displacement has really negative effects on health, as well as the event itself, right? In terms of the types of camps that they went to and infectious disease and that sort of thing. So it's certainly a complex question, but it sounds like the data is really sort of rich, and you're moving in all those directions. So it's really—
That's absolutely right, Kim. And just to follow up, and I won't take too long on this, just follow up. So we've also looked at child height outcomes. And what we saw was those people who were in utero at the time of the tsunami were at a huge deficit 2 years later. But by 5 years, they'd made up the entire deficit. And that, I think, is a real testimony to the incredible reconstruction effort. But of course, that's the average. And some kids didn't even come close to making up, and there's still a good standard deviation below their peers. So, it's complicated. And the beauty of the study design is that we can actually try and untangle some of these very complicated ideas. You're muted, Eileen.
Thank you for noticing that. Thank you, Duncan. I don't see any more questions, so I think we should move on. Jody Ford is next. Jody, let's see if you can share your screen. Good.
All right. Can you hear me okay?
Yes, I can hear you.
Yep.
Well, thank you so much for inviting us to present our research today to the Biomarker workshop. We appreciate it. We're actually at the other end of the life spectrum, focusing on adolescents. And I just need to advance here.
Yeah, you're not.
It's not showing as slide view.
Okay, let me see here. There we go. Better?
Yep.
Perfect. Okay.
Yep.
Thank you. And of course, we need to acknowledge our funding sources as well. This is a large project that's been ongoing, and we appreciate all the funding sources we've had. And a little bit about the background. We're focusing this study on looking at exposure to neighborhood and community violence among adolescents. And there's been quite a bit of research looking at its associations with mental health conditions, including depression, anxiety, post-traumatic stress disorder, suicide. And the studies from these show that there's some significance between exposures to violence at the community level. and that psychological and biological stress are hypothesized as pathways through which these violence exposures may impact the mental health outcomes, but there's been few studies that actually have tested these hypotheses. In addition, there's been some gaps in current research, particularly with the measurement at neighborhood and community level, which often relies on available administrative data that is taken from the census data generally, and it's focusing primarily on a single context of exposure, and particularly people mostly focus on the residential neighborhood of exposure and where people live. However, in our research that I'm about to present and some of the earlier studies we've done, that we found that adolescents actually spend 35% of their waking time in areas outside of their residential census tract. So when we just focus only on the residential neighborhood, while we're capturing some really meaningful information there, we are also missing exposures that they may have that they are experiencing outside of their own residential census tract. And then we also, some gaps with the research is that most studies so far with the exposure to violence and its effect has focused on looking at salivary cortisol and or measuring particularly diurnal curve or also acute stress responsivity, and looking at how differences in the acute stress responses in response to like a true social stress test may have its effect on exposure to violence. And there's been very few studies looking at longer term measures such as hair cortisol that perhaps might be able to better capture some longer term measures of stress biologically. So as I noted, our study here is we're focusing on the effects of exposure to violent crime, and we're focusing on their exposure in the adolescent's activity space, which encompasses the residential neighborhood in which they live, as well as other routine locations that they commonly go to, such as schools, peer neighborhood, peer houses, activities, and other locations they may go. And we're looking at the effect on perceived stress as well as on biological stress. We're using data from the Adolescent Health and Development in Context study. Dr. Christopher Browning is the PI on that study. And we have merged in data, which was a study linking biological and social pathways to adolescent well-being, which was data that we collected and in conjunction with the AHDC study, and to be able to look at hair cortisol. We collected salivary cortisol nightly for about 6 days, and also saliva for Epstein-Barr virus, and we are currently also assaying saliva for telomere length. And the study really is focusing kind of the effects of the activity space on youth behavioral, physiological and physical and mental health outcomes. So as I said, we're focusing on the activity space, and this is the set of places that individuals come into contact with this part of their routine activities. And as I noted earlier, this addresses some methodological issues related to classic neighborhood design, where we're focusing primarily on the exposure to just one location that youth may be exposed to on a daily routine basis. Our study is in urban Columbus and the surrounding suburbs. You can see the kind of circle here on the slide. That's the kind of outer belt of Columbus, and we focus here on the inner circle here. These outer suburbs of Arlington, Worthington, Dublin is part of Dublin is over here, and Bexley, and then in the surrounding kind of urban. It's an interesting city where you might be moving in one direction and you're in Columbus, and then you move in the next direction and you're in the suburb, and then go down the street and you're back in Columbus. So I think probably many cities are kind of along that way as well, how suburbs pop up. But this gives you a little bit of a picture of some of the diversity within Columbus, within that Beltway area, looking at differences that we can see by families who are living in poverty, with the darker levels indicating higher concentrations of poverty. You can see we have a highly segregated, racially segregated city with the darker areas, illustrating higher proportion of African-American population. And then also we have here, you can see the suburb areas are more likely to have higher concentrations of residents who have a college degree or more. So the sampling for our study was done in conjunction with the Center for Human Resources Research, who is, they work with NORC to conduct a national longitudinal study of youth. Our sample was representative of the study area, and it was the sampling frame was done through mailing, phone calls, door to door, and we also oversampled low-income neighborhoods. Community lay interviews actually collected the data. They were trained and they collected the survey and the biomarker data in the home. And we collected hair. We collected, similar to other speakers, we collected 1 to 3 centimeters of hair from the posterior vertex of the scalp. We used thinning shears, which if we have time, I can talk a little bit about that versus regular shears. We had a 91% participation rate in our study. Of those who did not participate, about half of those were refusal, and the other half were participants who did not have at least 1 centimeter of hair. We included those who had 1 centimeter of hair, less than the 3 centimeters, which is what is typically used, because we did not want to include any kind of selection bias into the study, as the majority of those who had shorter hair were male. Approximately 15% of the sample had less than 3 centimeters of hair. The study design was repeated over 3 waves. And you can see the study involved an entrance survey with the main caregiver and youth. There was also data collected on network partners. And then there was some extensive information collected from the youth and also their caregiver about all the routine locations that they went to on a routine basis, where they actually told us where they went. And then they showed us on Google Map of where they went. And I'll explain a little bit more the purpose of that. Then they carried a smartphone for over a week, in which they had EMA surveys sent to them approximately 5 times a day, and GPS location tracking was done continuously and uploaded to the CHRR server. And then the exit survey, we did some data cleaning when we actually went back and looked at the places that they went to try to clean, since the GPS is not always perfect in its locating individuals and where they went, and this helped clean up the data from that. There was a caregiver survey about their community perceptions of the communities and all the locations that they actually went to. And then this is the data point where we collected the hair for cortisol and saliva for Epstein-Barr virus and telomeres. So this exit survey that was an app that was actually developed for the program. And here I'll slip over to the side where the youth actually sat down with the interviewer, and they were able to put into kind of a Google map, say, okay, you say you normally went to this place, let's find it on the map. And then all of these locations were then actually fed into the youth's phone. So when they were getting the EMA, when they were asked where they were at, the routine locations where they were at popped up. So they could choose from one of those locations that was a common area, and then they also were able to enter in some other locations that they may be at that was not part of their routine activity. But it helped kind of reduce time for them when they were actually completing the EMA. So it was a little bit more, less burden on the participant to try to describe where they were at. But it also helped, as I said, because GPS data, while it is very useful, is not always necessarily 100% accurate in identifying where people's location they may be across the street versus where they were at. So they went over this as well at the end of the survey with the youth to kind of clean up where they were going and kind of identify the activities they were doing in these locations. So the activity-based measures are geocoded to the census block group. They were also taken from, as I said, this intense data collection through the GPS and the space-time budget. And they were linked to crime data that was available from the city, and also to the American Community Survey data. The activity-based measures are daily exposures, and they're weighted for the amount of time spent at each location, and they do exclude sleep time from the EMA reports that were determined from the time the youth was awake and the number of hours they slept. As I said, we got the data from the Ohio Department of Public Safety for the activity-based violent crime rate. We focused on this with the violent crime, looking at rates of homicide, aggravated assault, robbery, and rape. And the measure is actually constructed, it's the average violent crime rate exposure in the activity space over the 6 months prior to the survey. We had 2 dependent variables, perceived stress scale with Cohen's perceived stress scale, the Likert score, which I'm sure everybody's familiar with higher scores equaling greater perceived stress. And then, as I noted, we looked at biological stress with mean hair cortisol levels. We were using an ELISA-based assay, and the measures were log transformed for analyses. We did examine nonlinear measure of the cortisol as well. Some of the work we've done with the hair, we have found in predicting things such as depression that lower levels and higher levels of hair cortisol predict depression in adolescents. So we did want to also explore that here to see if we would see any kind of nonlinear relationship, and we did not for this, this particular analyses. We had a lot of control variables in the models, the typical sociodemographic variables, also looking at pubertal development and weight status. We do include a season of data collection because there is, the data was collected year round with these kids, and we do see some differences in findings based upon season. For the hair cortisol analysis, we looked at frequency of hair washing, controlled for hair length and chemical use. And then we also looked at their own individual levels of victimization, witnessing, and perpetration of violence. And then some control levels of the control variables, sorry, for the activity space measures. The sample, we did exclude the youth if they used corticosteroids in the past 3 months. There was about 33 youth who had done so, and also cortisol values that were outside the curve. We had 2 influential cases, and they had actually, one had very low cortisol and one had a very high cortisol. And looking at the diagnostics, they did show some influence on the results. So our final, it didn't really actually change the results much, but we did go ahead and take them out. But the final sample size is 518. And then our analysis was done using multivariable linear regression, and we imputed missing data. The most missing data I'll show you here, will be on the next slide, that we saw was for puberty. But you can see here is just some basic descriptive statistics on the measures of interest. And just, I want to kind of highlight our sample has some nice racial disparity, particularly just primarily from Black and white youth. We don't have in Columbus a very high prevalence of Hispanic youth or Asian youth. Both populations are increasing, and particularly since our data has been collected, we are seeing some more growth in these areas. But we do have a nice range between Black and white youth, and the majority of the mixed race youth are Black and white. And then you can see our diversity within education level, as well as income. The largest number of missing data here was actually for pubertal development. And a lot of these kids just rate that they don't know where they're at on their puberty level. So which is, I think, probably pretty normal that kids may, especially younger kids, may not know quite yet where they are, how far along they are developed. And I'll just point out here, I do have I have the additional, if you want the information, results for all the descriptive characteristics here, but the severe victimization in the past 12 months, there was 33 youth who reported that. So in our results, in the model 1 is unadjusted model with just kind of a bivariate regression, and model 2 has the full set of controls. But you can see as the average activity-based violent crime rate increased for both logged hair cortisol and perceived stress, we saw more stress for both of those outcomes. However, in the model, when we're controlling for all the other measures, we see the result is significant for the logged hair cortisol only, but we don't see that the result is there for the perceived stress. With the other significant covariate relationships, we do see a significant disparity between Black and mixed race adolescents having higher hair cortisol than whites. Older male and overweight adolescents had marginally higher hair cortisol levels, and those who had shorter hair and chemical use had lower hair cortisol levels. With perceived stress, we saw quite a bit of significance with lower income youth reporting higher levels of perceived stress, those with more advanced pubertal development, overweight, with higher rates of perceived stress. And then those who perpetrated and also were victims of severe violence in the past 12 months reported higher levels of perceived stress. And male adolescents had lower levels of perceived stress than females. And certainly I have those slides if anybody would want those as well, but there's many tables, long tables worth of data points. So in just kind of summary, increasing rates of activity-based violent crime was associated with the higher hair cortisol levels, but was not associated with the perceived stress levels when we were controlling for the measures. This is not infrequent to see differences between perceptions of stress and biological measures of stress. Some thoughts of this may be that particularly when you are exposed to higher rates of violence in your community and your everyday activity spaces, that youth may seem, these things may be seeming as normative, and they may not perceive these as stressors as a part of their everyday life. There may be some, I just kind of touch with here too, and I think about some other potential reasons is that it kind of almost like a limitation is that we're kind of capturing this over time. We actually don't have kind of in relation to if they heard about any kind of exposure in the 6 months prior to their survey. We have another paper where we're looking at that with the salivary cortisol and timing of a police killing in relation to the cortisol level, and just kind of having a shorter time range of hearing about or knowing about a violent crime taking place on that may have a greater effect on, particularly we would see that on perhaps like a salivary cortisol level versus a hair cortisol level, because it's going to pick up that kind of acute event. Certainly youth may not want to report or admit that they have stress, but I think it's probably more that youth may not even kind of perceive these events. It's just kind of normal everyday activity and that's around in their everyday life. And of course, there's some measurement issues with the hair is measuring up to 3 months prior to, because we have clear 1 to 3 months, 80% of the sample had 3 centimeters of hair, which approximates 3 months of cortisol levels, where the perceived stress measure is only anchored on the prior month. Youth may also misreport perceptions of stress because it's a global measure as well. And perhaps if they are not stressed on the day of their survey, that could certainly maybe impact the way they're answering the perceived stress scale. As I mentioned, kind of some limitations of our study is that unmeasured effective timing of exposure to incident events in the activity space, such as murders that may be happening or other police killings, as I was speaking about. We also have some unmeasured effect of perceived safety in their activity space. We have some measures of that in neighborhood, but not across all of their perceived activity space. We have some of that in their EMA responses, but not kind of a reliable number for each activity space that they had every day to capture an accurate result for their perceptions of safety in their spaces. And then our design here in this study in particular is a cross-sectional design. Some long-term implications of this, we certainly need to focus on some longitudinal analyses. We actually do have additional hair samples. We have hair collected on all of the entire wave 1 sample. The study was originally funded just as an R21 and for the biological measures, which is about 500 youth, but we had such high rates of being able to collect the sample, so we continue the hair sampling collection for the entire wave 1 and also wave 2. So we have 700 hair samples stored for the second wave. And we're hopeful. We have a grant that is pending. We're hopeful that it will be funded that will fund the additional assay of these hair samples. It's also really would be interesting to look at testing the hair cortisol as a mediator with some of our health outcomes or mental health outcomes. And also looking at some potential factors that might be able to buffer the relationship that could point to some potential interventions such as social support or school or protective factors. And I will end there and see if anybody has any questions. Thank you.
So we do have a question from Martha McClintock. She asks, whether there was a main effect for being African American, or whether there might have potentially been an interaction where stress exposure was stronger or weaker among the African Americans?
Yes, there is a direct main effect where Black youth and mixed race youth had higher levels of hair cortisol. We did not interact that with exposure to violence to see if Black youth had differential, more stress compared to white youth if they were exposed to violence. We do have some analyses that we've been exploring, looking at the exposure to kind of having be directly victimized in the last 12 months. That shows, because kind of illustrating that youth who've been exposed to violence in the prior 12 months may have higher hair cortisol levels than those who are without those exposures when they are exposed to higher levels of violent crime rates in their activity space. There's only 33 youth who were exposed in the last 12 months. So it's kind of a small N sample there. So we're kind of looking at, perhaps instead of measuring the crime rate on a continuous scale, perhaps trying to look at it at some cut points to see if it makes it a little bit more stable of an estimate. I think we'll have a better measure of that with the full sample if we can get all that hair assayed, because there'll be about 1,200 kids then instead of 500.
Jody, Tom McDade is curious to hear more about the thinning shears and whether that might increase the acceptability of providing hair. Yes,
I do think it does definitely help with the acceptability of collecting the hair. They're very difficult to use, and it's much more tedious in the lab with the thinning shears than it is with using regular shears. And because when you cut the hair with thinning shears, you're not cutting evenly. You're not cutting every piece of hair, so you have to kind of hold the hair and pull it out across the entire hair shaft. So folks who have really long hair or very curly hair, it can get tangled up. We actually have moved away from using thinning shears to using regular shears. I've been using this though primarily with youth who are homeless. I've not run into any problems with them donating hair, but I think that they are more driven by the incentive than they are being concerned about having their hair cut. But I do suspect that we would potentially see a difference in our adolescents if we did not use thinning shears versus regular shears. It's much easier in the lab and gives you a really nice, clean quality sample. And it's just much less labor in aligning the hair ends, because it's really important to have the root end of the hair aligned.
So if there are no more questions, thank you. I think we'll move on to the next paper, and we're going to have two people talk on this paper. So Tom McDade is going to introduce the topic. Looks like we're moving even earlier in life. And then Stephanie, I believe, is going to do the slide sharing for the presentation. Tom?
Great. Stephanie, why don't you go ahead? Yeah, terrific. It's great to see everyone, and I especially appreciate your efforts to make this possible for us to get together. As it becomes more and more difficult to connect interpersonally, I think it's more and more important to connect by whatever means possible. So I've very much enjoyed the session so far today. I look forward to the subsequent ones as well. So thank you, Eileen, Teresa, Steve, Liz, for helping make this happen. So today, Stephanie and I are going to present a work in progress. It's a paper that we're hoping to submit over the summer. So your comments are very welcome, both as part of the session and also directly over email. Stephanie is a recent PhD from Wisconsin-Madison. She worked with Alberto Poloni and Jenna Nobles, and she's been postdocing with me with past year and a half, and just received an F32 award. And one of the aims of that award is to learn more about the integration of biological measures into community population-based research. So hopefully you'll get to meet Stephanie in person sometime soon, because she'll be part of our intellectual community moving forward. Okay, so the title is The Role of Early Life Environments in U.S. Socioeconomic Inequities in Adult Chronic Inflammation. And next slide. And, you know, there's no surprise to anyone in this room that we have these stark and growing inequities in health. And this is just one of many examples showing multiple cardiovascular disease outcomes and how they pattern in association with wealth. And then particularly in the US, this is it seems to be more of a dramatic problem. And there's nothing natural and fixed about being poor and having poor health. And we can talk about how in other countries of the world, actually some key health indicators are better for individuals who are poor than people who are more affluent in the United States. And so this is a pressing problem, and it motivates a lot of our research. And one of the important things that we need to consider are the mechanisms. So next, Stephanie. What are, and it's particularly of interest to many of us in this group, what are the biological mechanisms through which experiences may get under the skin, become embodied, and affect health outcomes later in life? Next slide. So a lot of us have interest in inflammation, chronic inflammation, the regulation of inflammation. And as we're all familiar, C-reactive protein has become an important biomarker of chronic inflammation, initiated early on, probably more than 20 years ago, by working in cardiovascular epidemiology, showing that chronic low-grade elevations in inflammation are independent risk factors for subsequent cardiometabolic disease outcomes. And next, Stephanie. And there are dozens, if not hundreds, of studies showing that levels of CRP are socially patterned in the United States. So we have consistent race differences, ethnic differences, as well as lower levels of chronic inflammation associated with education and income and wealth. Okay, next slide. So for those of us who are interested in a life course approach, exposures and experiences early in life may shape physiological processes with implications for health outcomes later on. And so I've conducted a series of
I think you're fading out.
Breaking up, yeah.
Maybe you should turn your video off.
Philippines, a Cebu longitudinal health and nutrition study.
Tom?
I can't hear anything.
Tom is in the Upper Peninsula of Michigan, and he may be in less than optimal situation.
Want to try calling in and using a phone instead? That might help for audio, because it'll use it. It won't be using Wi-Fi.
Yeah.
Stephanie, have you heard him present this before?
Yeah.
Well, I can definitely fill in. It looks, did we completely drop Tom? It looks like.
Nice.
That's what it sounds like, yeah.
Okay, okay.
Yeah.
I'll go ahead and pick up then, and hopefully he can join back in. So the graphs shown here are both from a study published by Tom in 2014 that looks at adult CRP by early life environment. So the idea is that birth weight is influencing inflammation in adulthood, which then has these longer term impacts on disparities in adult health. And the graph shows CRP in adulthood at the ages of 24 to 32, I believe. First on the left, it's, are you back?
Doesn't
seem like it.
So we see a gradient in birth weight, essentially, with lower birth weights associated with, or higher birth weights associated with lower CRP. And this actually becomes even more striking when you look at within sibling comparisons, which are on the right. And similarly, you see trends or patterns with breastfeeding in infancy and then adult CRP. This is from the same study, and you have first breastfeeding dichotomized as it was asked of parents of the Ad Health cohort, and a reduction in CRP with more months of breastfeeding, and this seemingly critical threshold with less than 3 months or 3 months or more of breastfeeding. Tom, are you back? Okay. And as a final point to put these pieces together, we also see pretty persistent disparities in birth weight and breastfeeding by socioeconomic status. For instance, in the US, you see individuals in the bottom income quartile at a 2.4 times greater odds of experiencing low birth weight, and you see similar patterns with breastfeeding and educational status. So this led us to look at not only what is the impact of breastfeeding and low birth weight on adult SES patterns in health and inflammation, but sorry, let me go back. This led us to not only want to look at the direct impact, but also how these early life environments are actually affecting the SES gradient in CRP and ultimately in health outcomes. So the objective is, again, to what extent are socioeconomic gradients in chronic inflammation traceable to socially patterned exposures in infancy? We use the Ad Health cohort data, which many in this panel, in this larger group are familiar with. To investigate this particular question, we focused on data collected in waves 1 and 4. So Ad Health is a US population-based cohort study that was initiated in 1994. It's drawing from adolescents enrolled in grades 7 to 12. The next series of data collection are shown here from top to bottom. And wave 4 was completed in 2008 and 9 when study members were aged 24 to 32. So this is the same data set used previously with the sibling comparisons. Over 15,000 individuals participated in wave 4. This entailed at-home interviews in combination with physical measurements and blood samples being drawn. The measurements we use or rely on for our analyses include for inflammation, CRP from dried blood spots. For SES, we constructed an index we created from individual income, education, and several neighborhood-based indicators of poverty and employment. Our two main early environment measures were low birth weight and breastfeeding. We dichotomized both based on categorical responses available. And additional variables used in our approach include BMI and other risk factors for chronic inflammation in adulthood. And we also look at parent SES, specifically education, as an upstream determinant of both adult SES and early life environment and adult chronic inflammation. Our analysis approach was as follows. First, we wanted to just plot the SES gradient in CRP in this population representative sample of young adults. Second, we further modeled the associations underlying the SES gradient using structural equation models and including the mediating role of BMI. And lastly, we have started to quantify the relative impact of early life environments on the SES gradient. In other words, how would improvements to birth weight and breastfeeding affect the actual SES gradient or slope in CRP that we observe? Here's our initial calculation of SES and the slope our calculation of the SES gradient in CRP in the sample. It's survey weighted, but without any other adjustments right here. We use the log 10 scale to account for the distribution of CRP values with the back transform values in milligrams per liter also noted at both extremes. For reference, the median CRP in the sample is 1.47, and the mean log CRP is 0.15. Our next step was to actually model the underlying associations driving this gradient. So this is an illustration of the general SEM approach, simplified a bit for ease of reading here, and we're still interested in feedback in this pretty simple model of how these relationships work. It is organized so that the proximate risk factors for inflammation in adulthood are listed on the right, and more distal or upstream factors earlier in life are on the left. We can start by looking at the right-hand side with proximate risk factors measured in adulthood. Based on existing evidence of the strong association between BMI and chronic inflammation, we included BMI as a mediator of the SES inflammation relationship. Our main measurements for early life environments are listed in black on the left. You can see we also included BMI as an important mediator between early environment factors and inflammation. As shown in the bottom left quadrant, we controlled for parent education across adjusted models, given its strong ties with early environment and with adult SES. So here's, again, the original unadjusted slope in CRP by SES. And here it is alongside the adjusted slope. The adjusted slope does not yet include early environment. Instead, or it's based on a model that doesn't include the early environment. Instead, it marks an adjusted SES gradient that accounts for more proximate risk factors and parent education. It's worth noting that at this point, this may be an over-adjustment for our study purposes as a baseline, as it adjusts for BMI, a factor we suspect mediates the causal relationship between early environments and chronic inflammation. Still, as we unpack that further, this offers a conservative starting point for then looking at the impact of adding low birth weight and breastfeeding. Keeping that in mind, we then add low birth weight and breastfeeding to the SEM used to produce this first adjusted slope, and we estimate predictive margins conditional on their most advantageous values. That produces the blue and green dotted lines here. What you see is that adding low birth weight alone to the model and conditioning on low birth weight equaling 0 does not alter the SES slope in CRP at all. However, adding breastfeeding to the model and conditioning on breastfeeding at 3 months or more flattens the gradient significantly. The SES differences go from statistically significant to insignificant, and this shift is driven by improvements at lower SES positions. And here, when breastfeeding and low birth weight are jointly added and conditioned on, the slope is the same in the model with, same as in the model with breastfeeding alone. This table simply summarizes the shifts in the slope presented in the prior figure, with the baseline adjusted slope at the top left and subsequent adjustments for breastfeeding and birth weight shown in added rows and columns. Again, adjusting for breastfeeding accounts for over half of the SES gradient, beyond adjustments for parent education and proximate risk factors. Here, results from the fully adjusted SEM are elaborated, showing the predictive marginal effects associated with each pathway of interest. What you can see in this figure is that the estimated impact of breastfeeding on chronic inflammation acts significantly through its negative association with BMI. And something I haven't really gone into detail with, but we actually added two-way interaction terms between several of these. So these are not just coefficient values, they're averaged predictive margins. And we can talk more about that if you're interested. In sum, we uncover new evidence, including first, how breastfeeding contributes significantly to the population distribution of adult chronic inflammation, specifically as it shapes SES-based inequities. This includes through BMI as a mediating pathway. Second, we do find low birth weight to have this, to not have the same magnitude of influence. However, this is complicated by counteracting associations with body mass, we believe, and relative to breastfeeding, there is not necessarily the same scale and breadth of a gap to close, but it is still an important factor as demonstrated in prior studies. These results provide important insights for future research and public health interventions, as chronic inflammation serves as a key preclinical indicator of adult morbidity and mortality, particularly for the study population nearing middle ages. It adds also to an accumulating evidence of the importance of early life interventions for addressing population-based rates of chronic inflammation and inequities. For instance, based on our sample, or based on our analysis right now, universal gains in breastfeeding duration to at least 3 months would plausibly account for population shifts in the geometric mean of CRP as follows. It could lead to a 38% reduction among the lowest SES position, and also a 75% reduction in the SES gap. In other words, the change in the relative difference between the lowest and highest SES groups. With that, thank you. I know I sped through a lot of that, so please let me know if you have any questions. And hopefully Tom can chime in if he's available now.
Stephanie, congratulations on your excellent work on the trial by fire there. Very nicely done. There's a bunch of questions coming up. One is that although CRP is increased in chronic inflammation, it's often considered a marker of acute inflammation as well. Did you guys eliminate participants with acute inflammation or restrict attention to just a, sort of a chronic inflammation bandwidth? Do you have any limits or range on how you guys, what CRP data you incorporated in these analyses?
All right, I can try to take that.
Oh, yeah.
Can you hear me? Good. I need to talk while I can before I get, in case I get cut off again. Stephanie, great job. Thanks for stepping in there. My internet has been totally stable all day at the moment I'm talking. It, for some reason, goes out. So apologies. The question about acute versus chronic inflammation is a very important one because CRP is indeed an acute phase protein. It goes up dramatically in concentration acutely in response to infection or injury, but there is evidence for chronic low-grade activation, which is associated with increased chronic degenerative disease risk. So to use it as a marker of chronic levels of inflammation rather than acute, we eliminated individuals who were reporting symptoms of infectious disease at the time of blood collection or recently. And then we also can eliminate high values like above 10 milligrams per liter. That's a commonly used cut point for acute. We actually decided not to do that in this case, but as part of our robustness analyses, we'll look at different cut points and different ways to eliminate individuals who may be acutely inflamed rather than.
And we have another question from Kim. She asked whether you considered racial differences and if SES gradient might differ by race.
I can take,
yeah.
Oh, go ahead.
Yeah, go do it. No, you do it, Sophie.
We definitely think that's an important dimension to this. With our current approach, we're already stratifying by multiple things, so it leads us to kind of reduce our sample size a bit, but it's definitely something that we want to look at and see if we observe any differences. Do you have anything to add, Tom?
No, that's great. I think it's an important question. We're starting with the SES and we'll take it from there.
Mm-hmm.
You guys, we also have a comment from Martha McClintock saying, "Hi, Judy, I think you have the capacity to beautifully quantify institutionalized racism, economic, policing, anticipated violence exposure." Is that something that you have any comments on beyond accepting congratulations?
Yeah, thank you. We do have quite a number of papers kind of in progress looking at some of these. And as I was reading this, I was just thinking about how it would be potentially nice to have them kind of grouped together, and maybe some kind of a special issue with different people working on different projects in a themed journal article, perhaps. the data really does offer, I think, you know, and the kudos goes to Chris Browning and his development of the survey and really being able to tease apart a lot of these exposure places and spaces that youth have, and being able to kind of append it with some administrative, but also some of the social survey data we have. So thank you.
And another comment from Kim says, I would be curious to know if you've considered racial differences and if the SES gradient differs by race. I think this is for the last presentation.
Right, that relates to the first question. I would say it's definitely a next step to try to see if we can reproduce these findings across racial subgroups. We haven't done that yet.
Duncan has his hand.
I don't see.
Duncan
Yeah, I don't see any other questions. Oh.
I'm using the hand approach.
Oh, okay.
Why don't you just ask your question?
I can, if I can. My question is very simple. Stephanie Ton, that was an incredible paper and extraordinary presentation, Stephanie. I would really like it if my co-author stepped out during the presentation. My question for you is what I wasn't sure about. Your conclusions seem to me to be about inferring the results were causal, that if we had interventions, these would have the following effect. Do you interpret your evidence as causal?
I think we need to be careful there, obviously. I'm convinced that there's a causal relationship between birth weight, and whatever that means, but as a proxy, and chronic inflammation later in life. I'm convinced that there's a causal relationship, and there are good biological reasons to think so, which we could go into, between breastfeeding duration and level of chronic inflammation later in life. So then the question here is, if we assume that that is true, and that we know that birth weight and breastfeeding are socially graded in terms of the ability of people to deliver full-term, full birth weight, and to breastfeed for longer durations of time, is that an early life origin of this gradient in chronic inflammation that we might see later in life? So it's sort of a thought experiment.
So I guess I'm not sure it's a thought experiment. I understand that the biological underpinnings are extremely informative and valuable. What I'm not sure about is, do we know that the people who are choosing to breastfeed for 3 months and longer are going to be have the same, if we were to move other people who were not making that choice up to 3 months, would they have the same effects? Is it all driven biology, or are there behavioral factors, as you say, that are socially patterned that matter? And it seems distinguishing those, if there's a way, I guess, if you agree you're not doing that at the moment, if there's a way for you to think about doing that, maybe using the sibling differences, or something like that, where you can sweep out the maternal characteristics. So maybe she didn't have time, she got a job or something like that. That would be, I think, incredibly powerful, because then the intervention statement has a stronger foundation, I think.
Yeah, well, I totally agree. And breastfeeding is hopelessly endogenous, especially in the United States. In that 2014 paper with the AdHealth data, we did do sibling difference models. And I was about to talk about that when I got zapped out. I'm not sure exactly what Stephanie said, but you know, those families where one sibling is breastfed and another one is not, there's something probably unique happening there. But nonetheless, in those sibling difference models, we do get really strong associations between breastfeeding shorter or longer than 3 months and CRP later in life. So that to me gives me some confidence that those associations are causal, even though there are lots of other things that come along with the opportunity, the ability to breastfeed, like you're saying. I would like to move to some other instrumental variables or natural experiment approaches to looking at the long run effects of breastfeeding. And that's something
I think that'd be great. And I think if you brought in some of the stuff from the 2014 paper to, you know, maybe that's in the paper, but I think that would be very helpful. You know, and also I think there are a number now of RCTs which try to encourage or increase the length of breastfeeding. And those would be really good things to follow long term. Unfortunately, most RCTs stop after 3 months.
Yeah, that's right.
Which is a real scientific problem.
Absolutely.
We have a couple more questions here, you guys. One, could I ask Stephanie and Tom if they considered including the number of siblings in their model?
Yeah. It's not in there now, but it's a good point.
Yeah. Yeah, these are all great suggestions. Thank you.
And then another comment or question, breastfeeding may capture maternal attachment.
Mm-hmm. Absolutely. I mean, breastfeeding, it's a package. It reflects and enforces a lot of different things. So this is particularly why it's as Duncan was saying, I think, difficult to isolate the direct causal impacts because it was related to so many other things. So we're doing the best we can, and with you know, a variable that's very endogenous, but there are lots of other important things that come along with breastfeeding, including attachment.
Yeah, I'll add to it's really tricky to balance the building the rigor to test these causally while also trying to really look at the population distribution, right? Because the more you control for more things, the more it's no longer really about the representative distribution in the US right now. Obviously, you can't have the best of both worlds in that if we're not controlling for enough or we're not testing enough, then we can't really interpret things as causal, and there's still that desire to move that direction for thinking about interventions. But any additional feedback, or if you want to follow up with us on ways to test the robustness and maintain this examination of the distribution given the representative nature of ad health, I think that's what we're trying to do.
Mm-hmm. One more follow-up question from the same questioner. Why do you think 3 months of breastfeeding matters? Is there something magical about that? Is that semi-arbitrary? And in fact, it may not be a bad idea to have Dr. Lee unmute and ask the question, because different emphases in the question could convey actually somewhat semantically different questions. So it might not be bad for the questioner to chime in here if possible. But in any event, if you guys have any initial responses to that, please let us know.
Sure, I can respond, and I'd be happy to, you know, have an exchange if that would be helpful. I think the 3-month interval is partly an artifact of the time and the data. So the way the question was asked, the mother was asked to report on the duration of breastfeeding, and that variable was binned into not at all, less than 3 months, more than 3 months, 3 to 6 months, and so on and so on. Also, when the ad health cohort participants were born, it was historically at the nadir, just coming out of the nadir of the frequency and duration of breastfeeding in the United States, and it was beginning to become more accepted and recommended. So the cohort actually had lower frequency and duration of breastfeeding than subsequent birth cohorts have had, which is a good thing. And so I think if we were to do the study today, that we might not quite get the same pattern that emerges around 3 months. But in the context of this study, I think 3 months probably represents a meaningful commitment on a family to breastfeed that baby. And 3 months nutritionally, immunologically would sort of be at the lower end of what we would consider to be a duration of time that would have some meaningful short-term and potentially long-term effects. But it also could be that that 3-month commitment also reflects attachments and other aspects of the family and the mother that are carrying forward. We just don't know for sure. But that's why we're around 3 months for this study.
Any other questions?
I have one more question. So I'm Jin-Lee. So you didn't find the effect of birth weight, but breastfeeding. So when you put birth weight and breastfeeding separately, did you find any effect of birth weight? What I'm saying is that without controlling breastfeeding, did you find any birth weight effect? Because birth weight effect is like what is the Barker's hypothesis is very well-known predictors of later health outcome. So I just very curious about your initial finding.
I can start and then Tom can probably follow up. Because for this paper, we were focused on the SES gradient, we found that low birth weight didn't necessarily predict how that would shift. However, Tom's prior paper does find an association between low birth weight and adult chronic inflammation. Do you want to add anything to that?
Yeah, I can just add briefly that also, if you're born lower birth, there are lots of reasons to be a lower birth weight, one of which is that you're just a smaller person born to smaller parents, and there are some genetic factors in play. And lower birth weight, then you tend to have lower BMI, which also reduces CRP later in life. So to reveal an association with birth weight and chronic inflammation, you often have to adjust for waist circumference or BMI, and then a significant coefficient will often emerge, and that's the case in several studies, including some that we've done. So that's one reason why that in our modeling it may not show up as strongly initially as we might anticipate. The other is that birth weight and breastfeeding are correlated. Bigger birth weight babies are more likely to be breastfed for longer periods of time. So I actually think that some of the associations, some of the Barker hypothesis studies that are loading a lot of explanatory power to birth weight, that might actually be a proxy in part for longer breastfeeding duration. So we're able to disentangle that a little bit with the AdHealth data.
Any other questions?
I'm not seeing any other questions.
May I have, I'm sorry, can I have one more question?
Sure.
So this for me is really interesting. When breastfeeding importance is publicly educated, what I'm saying is I'm curious about whether you can replicate the finding for younger generation. The reason is that the birth weight is really increased for the cohort whose adolescent cohort whose parent is maybe younger older generation who initiated the breastfeeding may be more motivated, more intellectual, more care about their children rather than people in the other generations. So maybe underlying background they have it, maybe again attached to their breastfeeding behaviors. So what is it? Do you think it can is a really breastfeeding effect or the generation, like the reflecting? What do you think?
Yeah, well, I think those are important issues. I mean, it gets at sort of the, what is breastfeeding really representing here, and is it a direct causal effect on inflammation? And there are multiple pathways, multiple things that could represent, and patterns of association in one context may not replicate or generalize to others. My prior is that that we should, as a society, support women and families to be empowered to make the decision to breastfeed if they want to do so and it works for them. And a lot of the language and the conversation about breastfeeding gets loaded onto women in particular, and individual choice and knowledge, but really it's a very difficult thing to do. It takes a lot of support, and at the policy level, at the community level, at the family level. And so I'm more interested in talking about the contextual factors that influence the likelihood and the ability to breastfeed. And there's very little data to fit to that question in terms of the long run health benefits or potential costs of breastfeeding. So this is one of the reasons why I'm interested in this topic. There are a lot of data on the short run benefits of breastfeeding, but much less so on the long run benefits, which then need to be weighed against the potential costs, particularly for women as they bear the disproportionate burden of responsibility for caring for infants.
Any other questions? Well, thank you, everybody. Eileen, do you want to unmute? And
yes, I think this was a great meeting, and the papers went together very well, and I'm glad to see everybody and have visited. We'll visit again on Friday, and we're happy to welcome Stephanie and her inaugural appearance, impromptu, but I do want to mention that Ralph Lawton, who was on Duncan's, the paper Duncan presented, just graduated from undergraduate. So we are producing a new generation here. That's what we want. And
go
invite your
Go
students
Ralph.
to the next couple webinars if you want to. So thank you very much, everybody. I think we'll end this webinar. And so we think that 2 hours is about as much as anybody can take on Zoom. So that's why we're 3 days of 2 hours. So we'll see you again Friday and then again Monday. Hopefully we got some of the wrinkles out of our system today, and we'll even be more efficient next time. So goodbye. Bye-bye.
Thanks, everybody.